We are on live. We are good to go now.
A very good evening to all of you. I'm Hetal Gohil, and it's my privilege to welcome you all to today's insightful webinar on Resmetirom Pharmacotherapy and Clinical Approach in MASH. Metabolic dysfunction associated steatohepatitis, or MASH, represents the progressive form of metabolic dysfunction associated liver disease. It affects almost 30% of global population and nearly 55% of Indians. MASH is strongly associated with metabolic comorbidities such as obesity, type 2 diabetes, hypothyroidism, hypertension, and dyslipidemia. Unfortunately, the condition is often asymptomatic and leading to delayed diagnosis, early identification, and timely intervention, particularly in patients with fibrotic stage F2 and F3, is therefore very crucial to halt the disease progression and prevent irreversible damage. Despite extensive research over the years, there was a critical need for effective pharmacotherapy in patients with MASH and advanced liver fibrosis. Today, with the advent of Resmetirom, the first US FDA-approved liver-directed oral therapy for non-cirrhotic MASH with moderate to advanced liver fibrosis, we are entering in the new era of hepatology. Resmetirom selectively binds or targets THR beta receptors, plays a pivotal role in regulating hepatic metabolism, helps in reversing MASH pathology. This milestone reinforces our commitment in bringing cutting-edge science closer to the clinical practice and improving patient outcomes across India. To explore this topic, it is my great honor to introduce our esteemed speaker for today's session, Dr. Vinit Shah. Dr. Shah is a senior consultant in hepatology, liver diseases, liver transplantation medicine, and gastroenterology at Ruby Hall Clinic and Pune Hospital Research Center, Pune, with over 10 plus years of extensive experience. He is a National Board of Examinations gold medalist. He has presented multiple papers at prestigious annual international liver disease conferences, including American Association for the Study of Liver Disease and European Association for the Study of Liver. He is also a recipient of Department of Science and Technology, Government of India International Travel Grant and Young Investigator Award. Dr. Shah has multiple publications in reputed national and international journals. His special areas of interest include acute kidney injury in cirrhosis, acute on chronic liver failure, endoscopic ultrasound in cirrhotics, and liver transplantation medicine. With the great pleasure, I now invite Dr. Vinit Shah to lead today's session. Over to you, sir, and I sincerely thank everyone for joining us today evening. Thank you.
Yeah, good evening, everybody, and thank you, Hetal ma'am, for introducing me and the kind words. So now we have lot of good options available for treatment of metabolic associated steatotic liver disease, and resmetirom is a very good molecule which we have available now. I have had the privilege of using it in almost over 30 patients in last 3 months, and I feel I have had a very good experience with the use of this molecule. So I thank Hetero Healthcare for giving me an opportunity to present my insights about this topic. So I would like to share my slides. I will just do it. So am I audible and are my slides visible?
Yes, sir.
Yeah. Okay, so basically, I would discuss today's topic taking help of a real life case which I had worked up, and I think so. Case based discussion will be very useful in helping us to know what is MASLD, what is fibrosis, and where does resmetirom position itself in the treatment of MASLD. I would also like to give a very crisp summary of the other options which we have when we compare it to resmetirom and where we should use it in the treatment of MASLD. So the case is a 38-year-old gentleman. He is obese. He had a BMI of 30 kg per meter square, weight of 100 kgs. Lifestyle changes were being aggressively followed by him for 2 years, following which he lost weight from 100 kgs to 88 kgs. His BMI came down to 27. He's also hypertensive for a lot of years, dyslipidemia for 4 years. He had very significant family history. Two of his maternal uncles died in the late 60s and early 70s because of cryptogenic liver cirrhosis. Both the maternal uncles had diabetes, coronary artery disease, diabetic microvascular complications, peripheral vascular disease, and chronic kidney disease. One of the uncle also had hepatocellular carcinoma. Another important history, his own father died due to liver cirrhosis. Father also had diabetes. He was not obese, which is an important part of the history, and he had alcohol history. Maternal cousin also was diagnosed by me. He happened to be my patient to have chronic active hepatitis with dyslipidemia. So this maternal cousin was thoroughly worked up by me, and he was found to have vitiligo, had received methotrexate for many years, thyroiditis, was on thyroid supplement, hypertension for 10 years. So I got his liver biopsy done in 2023 April, and he had diagnosed to have NASH because that time MASLD was known as NASH with a CRN score of 4 by 8, fibrosis score of 1B. So now this is the summary of all the labs of our patient from 2018. All his HbA1cs were between 5.9 to 6. IgG level was normal. Ceruloplasmin was normal. Viral markers were negative. Total core was negative. Autoimmune markers were normal. Dyslipidemia was there in all his lipid profiles. His bilirubin, platelet count, and INR were normal. So this was the trend of his LFTs. If you see, from 2018 till 2025, he always had a transaminitis. AST was 85, 133, 79, 142, 85, 130. 2023, it was 101, 142. These were his present labs when he came to me in the month of July 2025. He had a hemoglobin of 15, INR of 1, platelet count of 179, GGT of 80, HbA1c of 5.7. He had cholesterol of 151 in spite of being on statins, triglyceride of 198. He had a MR elastography value of 4.6, fibroscan value of 16.5 kilopascals with a CAP value of 280. I got his liver biopsy also done. I will come to the liver biopsy subsequently to introduce the concept of what is inflammation and what is fibrosis. He was currently on statins and antihypertensives. So this is about the treatment of MASLD. So what is the first step when we see about a patient of MASLD? A very important step is to identify whether the patient is having significant fibrosis or not. Because it is always important to catch those MASLDs where there is more fibrosis. Because the more fibrosis MASLDs are the ones which are at high risk of progressing to cirrhosis, hepatocellular carcinomas, portal hypertension, and complications. So, a very important score is to calculate the FIB-4 score, which is very easy to calculate on Android or iOS apps. You just need the values of the AST, ALT, AH, platelet count, and you get the FIB-4 score. So FIB-4 score of less than 1.3 sufficiently rules out advanced fibrosis, and the patient is at low risk of developing a advanced fibrosis. A FIB-4 score of more than 2.67 is at a high risk of fibrosis, and then we have to refer this patient to an appropriate hepatologist or gastroenterologist because they require a full workup for advanced fibrosis, mainly in the form of transient elastography, blood test, or fibrosis markers. Now, this is the change in the nomenclature. NAFLD is recently named as metabolic dysfunction associated steatotic liver disease, and NASH is recently named as metabolic dysfunction associated steatohepatitis. So, this is the spectrum of steatotic liver disease. You have the metabolic dysfunction associated steatotic liver disease, where you have only fatty liver, which is known as metabolic dysfunction associated steatotic liver, and metabolic dysfunction associated steatohepatitis. And then you have the other spectrum, which is beyond the scope of discussion in this lecture, where you have a new concept known as MAT-ALD, where the features of MASLD are there with increased alcohol intake, where you have MASLD predominant MAT-ALD or ALD predominant MAT-ALD depending on the quantity of alcohol. And then you have rarer causes of steatotic liver disease. So that's why this fifth four score is a very important take home message from this case. And all of the patients of fatty liver disease coming to our OPD, we should make an attempt to calculate fifth four score or NAFLD fibrosis score, because the fifth four score more than 2.67 is the targeted population where very aggressive search for high fibrosis should be done. Also, a fifth four score between 1.3 to 2.7 is also very important. Now coming to the importance of the two things. One is the NAFLD activity score and one is the fibrosis score. These are the things which are very important to know, because we have basically two things which are seen in all the drug trials. When I will subsequently come to the MAESTRO trial, which was done for resmetirom, these are the two concepts which are very important to know. So NAFLD activity score is a composite of three things. One is steatosis, one is lobular inflammation, and one is hepatocellular ballooning. So steatosis is graded on 0 to 3. Lobular inflammation is graded on 0 to 3, and hepatocellular ballooning is graded on 0 to 4. So when a score of more than 4 is there, then there is a diagnosis of NASH. NASH resolution in drug trials which are done for MASLD is either achieving a ballooning score of 0 or a lobular inflammation score of 0 to 1, and the NAFLD activity score is reduced by 2 points. So you should remember the three components of NAFLD activity score: steatosis, ballooning, and lobular inflammation. And a response in the NAFLD activity score of more than 2 points, or a reduction in the ballooning score or the lobular inflammation score, is an important thing which is used in all MASLD trials. Fibrosis ranges from F0, which is no fibrosis, to F4, which is cirrhosis. So this is the biopsy of our patient now. As you can see, there is lot of macrovesicular steatosis in the hepatocytes. This is the foci of macrovesicular steatosis. So this is the concept of ballooning degeneration. You see that the hepatocytes get ballooned because of the fat cells. So this is an important concept of ballooning degeneration which is seen in MASLD patients. And with this steatosis and ballooning degeneration, you get foci of inflammation around the hepatocytes, where there is involvement of hepatocytes by neutrophils. So this is the foci of lobular inflammation which is seen. So steatosis, ballooning, and lobular inflammation, these are the three important concepts which we see in liver biopsy. And last and important is the fibrosis, where you can see these bands which are getting connected. So this is a case of bridging fibrosis. So this patient had a MASLD with MASH with a CRN score of 4/8, fibrosis score of F3. So I initiated him on resmetirom 80 mg and a regular follow-up was suggested. So now coming to the concept of resmetirom. So basically, what does the thyroid gland do? So thyroid gland basically, as we know, is located in the neck, and the important hormone is T3 and T4, which are important for all the important mechanisms of the cell, and they mainly carry out their mechanism by two receptors, THR alpha and THR beta. So what does the thyroid hormones do in the liver? In the liver, basically the most important thing is they regulate energy and metabolic homeostasis, and they also control the hepatic insulin activity and suppress the hepatic gluconeogenesis. So basically these are the two important functions. One is regulating energy and metabolic homeostasis. They do it by modulating the export of lipids from hepatocytes into the bile and bloodstream, as well as oxidation and de novo lipogenesis, process of conversion of excess carbohydrates, proteins or alcohols into fatty acids, and also the insulin sensitivity and decreasing the hepatic gluconeogenesis. Basically, what happens in NASH is a hypothesis that there is alteration in the normal thyroid activity at the THR beta. So the thyroid hormones don't act in a proper way at the THR beta receptor, and that's why the energy and metabolic homeostasis and the hepatic insulin sensitivity get disturbed. This is, as we know, the feedback loop of how the thyroid hormones act. You get signal from hypothalamus, which stimulates the pituitary to secrete TSH, which stimulates the thyroid to secrete the two types T3 and T4, and then they act at the cellular level. So there are two types of THR receptors, thyroid hormone receptors, in which you should know that the THR beta is a very liver specific receptor, and mainly the thyroid hormones act on the liver by this THR beta receptor, which is a very specific receptor and which takes into consideration all the cellular functions of the liver cells by proper translation and transcription. So what does the thyroid hormones do? After release from the thyroid gland, they enter into the liver cells, and in the liver cells there are two enzymes, DIO1 and DIO3, which convert the T4 into T3 and reverse T3. This T3 then acts through the THR receptor, and then they bring about the various cellular functions. And the most important functions are they reduce the liver fat, reduce the lipotoxicity, reduce the triglycerides, LDL and ApoB. So now coming to this important thing is, so we saw how the beta receptors act. So now we should know how, when we use resmetirom, how should we monitor? So it is very important that we use the NILDA or the non-invasive liver disease assessment. And the two important values which we should remember is that a VCTE, that is a fibroscan improvement of more than 25%, or a MR elastography of more than 20% improvement is important, which indicates a beneficial response. A VCTE of less than 25% or a MR elastography of less than 20% means an uncertain response. And if the values of fibroscan or MR elastography worsen, then it indicates that there is no response. So when using resmetirom, if we are using sequential fibroscans, we should see that there is a 25% reduction in the fibroscan or a 20% reduction in the MR elastography. And if we are having a less than that, then we have to reevaluate the strategy. If we have worsening of the fibroscan or MR elastography or increase in the ALT, then it indicates no response and we should stop resmetirom. So these are the EASL guidelines about MASLD. So without cirrhosis, the direct targeted therapy which is locally approved is resmetirom, which is recommended by US FDA in F2, F3 fibrosis. With compensated cirrhosis, mainly the recommended things are HCC surveillance. And the other important thing is that you have to take care of the comorbidities. So if there is diabetes, dyslipidemia, obesity, you have other options available. So you should understand that NASH is not only targeting one particular disease. MASLD comes with lot of comorbidities. So basically, you need a structured framework of pharmacotherapy in which you have the MASH targeted therapy, which directly targets the fibrosis, in which the only recommended molecule is resmetirom. And you have molecules which target the other comorbidities. So, for diabetes, you have GLP-1 receptor agonists like semaglutide, you have SGLT2 inhibitors, you have metformin, you have In dyslipidemia, you have statins. And for obesity, you have GLP-1 receptor agonist or dual receptor agonist like semaglutide and tirzepatide. So now coming to the current gaps in pharmacotherapy, basically we know that the thyroid hormones have a very important role in THR beta receptor signaling, and it is important that when this signaling is affected in MASLD, there is lipid metabolism which gets impacted, there is fatty acid oxidation process which gets impacted, which leads to worsening of NASH and fibrosis. So there is a need for liver directed therapy in the management of MASLD. So here we have now resmetirom available, which is mainly recommended in non-cirrhotic MASLD with moderate to advanced liver fibrosis. So basically, what is resmetirom? Resmetirom is a oral thyroid hormone beta receptor agonist. It was approved by US FDA for the management of non-cirrhotic MASLD with moderate to advanced liver fibrosis. It also received conditional authorization from EMA in June 2025 for the treatment of MASH with moderate to advanced liver fibrosis. How do we use it? Less than 100 kg 80 mg once daily, more than 100 kg 100 mg once daily. The only thing is, if your patient is concomitantly on clopidogrel, then less than 100 kg you have to use 60 mg and more than 100 mg you have to use 80 mg because of the interaction, because of the CYP2C8 inhibitors like clopidogrel. As we told, resmetirom is a partial agonist of the thyroid hormone receptor beta. It has a very strong affinity, which is 20 times more for thyroid hormone receptor beta than thyroid hormone receptor alpha. And basically, this is mainly 84% of the maximum activity that T3 hormone has at the receptor of the THR beta. So what does it do? The thyroid hormones regulate mitochondrial biogenesis and hepatocyte function. It lowers the thyroid hormone, and if the thyroid hormone function is lowered, it can result in lipid accumulation and impaired mitochondrial function, which contributes to the development of MASLD. So, resmetirom acts by THR beta signaling, and it improves the lipid metabolism, mitochondrial biogenesis, and reduces the inflammation. So it selectively targets the THR receptor beta, which predominantly is expressed in the liver. And it is a very important in the pathogenesis of MASLD. So what does resmetirom do? It stimulates the THR receptor beta, and it leads in expression of genes which improves the mitochondrial biogenesis and lipid metabolism. And basically it exhibits 84% activity of the natural T3 hormone, as we just saw. So it enhances the uptake of fatty acids, promotes cholesterol breakdown, and improves the fatty acid oxidation and mitochondrial biogenesis. It also suppresses the de novo lipogenesis and fibrogenesis. It also improves the insulin sensitivity and also lowers the apolipoprotein B, which is an important cardiovascular risk factor. So in short, resmetirom, because of its affinity, which is very high for the THR beta receptor, it enhances the uptake of fatty acids, improves the cholesterol breakdown, and promotes the fatty acid oxidation. It also reduces the de novo lipogenesis, and that's why it helps in the reduction in the fibrogenesis. So what are the other parameters? It has a oral bioavailability of 45%, Tmax of 4 hours. As we saw, it has metabolism through the CYP2C8 enzyme, and maximum of the resmetirom is eliminated in the fecal route and only small quantity is eliminated in the kidney route. So what are the contraindications to the use of resmetirom? Pregnancy and lactation are important contraindications. Pediatric population, concomitant use with strong CYP2C8 inhibitors like gemfibrocil, severe renal impairment or dialysis dependent patients, excessive alcohol consumption patients, active thyroid disease. So basically, it is recommended that thyroid function should be optimized before starting resmetirom. and it is not recommended in decompensated cirrhotics where the LSM is more than 20 or MR elastography is more than 5. Symptomatic gallstones or acute cholecystitis, again, resmetirom is not recommended. So, what are the warnings? We have to see that the rise in ALT or AST levels initial 4 weeks of treatment, and if it is there, then hepatotoxicity should be suspected and resmetirom should be stopped. Acute cholecystitis, pancreatitis are there in some of the resmetirom treated patients, and drug interactions, in which one of the most important interaction is with clopidogrel, where the dose modification is to be done, CYP2C8 inhibitors. Also, there is increase in exposure of statins and when they were concomitantly administered with resmetirom. So, in severe renal impairment, dialysis dependent, it is still not studied. Mild to moderate renal impairment, it can be used. There is child age cirrhosis, there is no dose adjustment recommended, but it should be avoided to be used in decompensated cirrhotic patients. And in cirrhotic MASLD, still the effectiveness of resmetirom and safety is not studied. Pregnancy, still there is no data. Lactation, there is no information available. Pediatric population, again, no data is available. And geriatric population above the age of 68, there was no difference in the effectiveness of the resmetirom, but over the age of 65, more adverse effects were seen when resmetirom was used. Drug interactions, strong or moderate interactions are mainly with CYP2C8 inhibitors, and concomitant use of these drugs with this is not recommended. If we have to use it with clopidogrel, then recommendation is to reduce the dose of resmetirom. Statins, resmetirom increases the plasma concentration of statins. So basically, when you are concomitantly using resmetirom and statins, you have to limit the doses of rosuvastatin or simvastatin to 20 mg and atorvastatin to 40 mg. So, what are the side effects or adverse reactions, which I also have seen in the patients? One of the most important side effect is diarrhea, which is seen after 15 to 20 days, nausea, vomiting, abdominal pain. Dizziness is an important side effect, which I also personally have noticed in some of the patients. So now coming to where did we get the data about use of resmetirom? So the best study which was there to recommend the use of resmetirom was the MAESTRO-NASH trial. As I had earlier introduced the concept of NASH resolution, I had also told you people about how NAFLD activity score is calculated. It mainly takes into consideration the steatosis, lobular inflammation, ballooning, degeneration. So Maestro trial also used the NAFLD activity score, and an improvement of more than 2 points was seen with no worsening of fibrosis, and improvement in fibrosis by at least one stage with no improvement of NASH or NAFLD activity score. So I had told you about these things. So what were the results of the Maestro trial? So basically, NASH resolution with no worsening of fibrosis was significantly achieved in people who received resmetirom as compared to placebo. This was a very important thing. Significant improvement in fibrosis by at least one stage with no worsening of NAFLD activity score was also seen in significantly more patients who received resmetirom as compared to placebo. LDL cholesterol, this was also a very important finding, significantly reduced at baseline to week 24 among patients who received resmetirom as compared to placebo. So at week 52, there was also reduction in level of triglycerides, apolipoprotein B, lipoprotein A. Levels of liver enzymes including AST, ALT, GGT seem to be decreased more in resmetirom group as compared to the placebo. And the liver stiffness as done by transient elastography or MR based appeared to decrease more in resmetirom related people as compared to placebo. Coming to the adverse events, diarrhea and nausea were more frequent events, and 80 mg and 100 mg, both doses were superior to placebo as compared to in NASH resolution and as well as one stage improvement in fibrosis. So basically, the adverse events were more or less similar in the control group as well as the resmetirom group. But as you can see, both 80 mg as well as 100 mg achieved both the primary endpoints. That is improvement in the NAFLD activity score without improvement of fibrosis, as well as improvement of fibrosis without improvement in the NAFLD activity score. So there was one more network meta-analysis which compared efficacy and safety of resmetirom versus semaglutide. So I will just come to the results. The results were that resmetirom had a higher efficacy in reducing the MASLD as compared to semaglutide, also higher efficacy in reducing the fibrosis and better changes in MRI PDFF as compared to semaglutide. So resmetirom demonstrated higher efficacy in resolving MASLD, improving fibrosis and reducing liver fat as compared to semaglutide. Semaglutide had a better benefit in weight reduction and glycemic control. Thus, it is a very good valuable addition with patients of MASLD with comorbid obesity and type 2 diabetes. So basically, how can we use resmetirom? So it is recommended in non-cirrhotic MASH with advanced or moderate fibrosis. So what has been taken a transient elastography value of 10 to 19.9, MR elastography of 3.3 to 4.9, and the other scores are there. Where we cannot use resmetirom is when the fibroscan or the transient elastography value is more than 20, MR elastography value is more than 5, and platelet count is less than 1,40,000 or there is evidence of portal hypertension. This is about a slide about the mechanism of semaglutide. So semaglutide, unlike resmetirom, this is a very important point to remember that the GLP-1 receptor agonists do not have a direct effect on the liver. They primarily have effect on the CNS by which they suppress the appetite, prolong satiety, reduce insulin resistance. In also they have a metabolic effects which are reduce the glucagon, improve insulin sensitivity, and as a combination of these two things, we see secondary effects on reducing the liver inflammation and fibrosis. So semaglutide as against resmetirom does not have a direct effect on the liver, whereas resmetirom is a direct liver targeted therapy which acts on TH receptor beta. This is a very important point to remember. Now, I would give you some comparative slides about the other options which we have. So, resmetirom, as we saw, is a selective liver specific action. Semaglutide, on the other hand, has an indirect liver action on the basis of improved insulin resistance. Resmetirom is FDA approved for non-cirrhotic MASH with F2, F3 fibrosis. Semaglutide is also recently FDA approved for MASH, but it has been primarily approved for use for diabetes and obesity. The key trial which studied resmetirom is the MAESTRO-NASH trial, which I just shared the important points. Semaglutide, the key trial is ESSENCE trial, which is 72 weeks and ongoing. So there was a good MASH resolution in both, good fibrosis resolution in both, but the weight loss effect is only modest with resmetirom, whereas the weight loss effect is significant with semaglutide. It is a direct liver targeted therapy. GI side effects are the main side effects. It is a oral therapy which can be used once daily, but definitely it can be combined with GLP-1 receptor agonist for additive benefit. Semaglutide, on the other hand, is mainly recommended in obesity, diabetes who have associated MASLD. GI effects are more common in semaglutide as compared to resmetirom and gastroparesis. The important thing to remember about semaglutide is the risk of non-arteritic ischemic optic neuropathy. So we should have the clear-cut eye evaluation before we use semaglutide. The important data which we have from ESSENCE trial is promising cardiovascular benefits for semaglutide. Now, how do we compare resmetirom with the drug which was available in India, that is saroglitazole? So, saroglitazole is basically a dual PPAR alpha gamma agonist. It improves the insulin sensitivity, modulates the lipid metabolism. It has been approved in India for use in diabetic dyslipidemia and NASH by INSL. The study which studies saroglitazole is evidences for trial. Important point to remember is whereas in resmetirom studies we have a biopsy proof of reduction in the NAFLD activity score and fibrosis. In saroglitazole we don't have a biopsy based proof yet. So this is a very important point which we should remember between resmetirom and saroglitazole, that we don't have a histological resolution of fibrosis data yet. Neither we have a histological resolution of NAFLD activity score data yet. Other important thing to remember is whereas there is a weight neutral or a modest weight loss by resmetirom, saroglitazole has a weight gain as an important side effect. So again, the ideal patient setting for resmetirom is biopsy confirmed MASLD needing histological improvement, whereas for saroglitazole it is mainly MASLD with diabetic dyslipidemia or hypertriglyceridemia. Now, how do we compare resmetirom with the other drug, that is the SGLT2 inhibitor? So, SGLT2 inhibitor blocks the renal glucose reabsorption, decreases the insulin, increases the fat oxidation and metabolic profile. So, mainly SGLT2 inhibitors are approved for type 2 diabetes, cardiovascular benefits, renal benefits. The MASLD use of SGLT2 inhibitors is only off label. Again, as we have histological data for resmetirom, we don't have a histological data. We have only a limited MRI or CT scan based data. There is also a modest weight loss with SGLT2 inhibitors, which is same as that of resmetirom. Important thing is there are no GI side effects of SGLT2 inhibitors, but there is an increased risk of genitourinary tract infections. So the setting of SGLT2 inhibitor is any MASLD where there is diabetes or metabolic syndrome, where we need a predominantly cardiovascular and renal benefit. Now, how do we compare resmetirom with tirzepatide? So tirzepatide is a dual GIP-1 GLP-1 agonist. It increases the insulin sensitivity, reduces the adiponectin, and decreases the liver fat and inflammation. Tirzepatide is approved for diabetes and obesity. It is still not approved for MASLD. The trial which studies tirzepatide is the Synergy-NASH trial. You can see that there is a very good NAFLD activity score reduction, fibrosis reduction. But the most important aspect of tirzepatide is a very strong weight loss effect, which is much higher than resmetirom. Again, the GI side effects are there with tirzepatide and they are more than resmetirom. So now I have summarized that what are the MASLD phenotypes which we get and what are the drugs which we can use. So type 2 diabetes, we can use GLP receptor agonists or SGLT2 inhibitors because they improve the glycemia and improve the cardiovascular risk profile. Any MASLD with obesity, GLP-1 receptor agonist or dual receptor agonist can be used because robust weight loss can be achieved. The data to support this is the STEP or Synergy-NASH trial. Any FLD, any MASLD with moderate fibrosis, resmetirom is the important drug because it is used in histologically proven NASH, and the important data about this is MAESTRO-NASH trial. Saroglitazole has a main indication only in atherogenic dyslipidemia because it improves the triglycerides HDL and reduces insulin resistance. Evidences 4 is the trial for this. When hypertension and metabolic risk is there, SGLT2 inhibitor with or without GLP-1 receptor agonist can be used because they have a very strong effect in BP reduction and also metabolic benefits. Established cardiovascular disease, again, GLP-1 receptor agonist with or without SGLT2 inhibitor should be used. It is on the basis of CVOT trials. CKD patients, again, SGLT2 inhibitors because of renal protection. PCOS with MASLD, GLP-1 receptor agonist with or without metformin can be used. Lean MASLD, resmetirom has a very important indication because here we need mainly the histological benefit. Weight loss is not the predominant thing which we want to see. Advanced cirrhosis has been eliminated in almost all clinical trials, and so there is no approved pharmacotherapy in MASLD with advanced cirrhosis. So to summarize, GLP-1 receptor agonists are anchor molecules of MASLD, and resmetirom is also very excellent molecule in the fibrotic MASLD. But you should know that when we use these molecules, we should know that we are running a marathon. We are not running a 100-meter race, and the process has to be slow, like running a marathon and winning it. We should not try to achieve, neither the patient should expect a dramatic or magical results over few months. It has to be over 6 months, 1 year, and it is always the marathon runner which wins when we consider MASLD treatment. And both resmetirom and GLP-1 receptor agonist should be used in a slow, gradual way so that we can achieve the targets in a proper way. So I thank you for your patient listening and will be very happy to answer any questions.
Thank you, sir, for such a wonderful detailed presentation and placing of each pharmacotherapy in the management of MASH. We have received few questions, sir. Um, so, so this is the first question, which says that according to you, which are the ideal patient to be prescribed resmetirom, and in terms of CAP or fibroscan values?
So as I told you, resmetirom is mainly recommended in fibrosis with MASLD. So I agree with the question that it is not practical to have a liver biopsy, neither it is practical to have a NAFLD activity score. So what the trials have taken is that a fibroscan value where we should give more importance to to fibroscan, the LSM value. There is no data about any cap value based treatment of resmetirom. There are only two ways. One is either the LSM value on fibroscan or the MR elastography value. So basically what I see is any fibroscan value which is more than 9.5 or 10 generally indicates that there is moderate to advanced fibrosis, and I think so they are the candidates which are important for resmetirom. So basically a LSM value of more than 9.5 to 10 is an important thing to be used when we use resmetirom.
Okay, okay, sir. There's this question of co-prescription of saroglitazole or semaglutide or tirzepatide along with resmetirom.
So saraglitazole, I told you, is mainly used in atherogenic dyslipidemia. As I also showed that there is also a weight gain with saraglitazole. So basically, in addition to MASLD with fibrosis, if dyslipidemia is an important problem, then only for the purpose of dyslipidemia we can use saraglitazole. I personally have not used saraglitazole and resmetirom together because I feel that resmetirom itself has a lot of beneficial effect on the lipid profile. The MAESTRO trial also shows that from 24 to 52 weeks, there has been a sequential improvement in LDL and other apolipoprotein B and other parameters. So I personally feel there is no strong rationale to use saraglitazole and resmetirom together. Coming to the use of GLP-1 receptor agonist with resmetirom. So personally, I have used semaglutide with resmetirom in 2 patients, and I have used tirzepatide with resmetirom in around 3 patients. What I have seen is mainly a very obese MASLD phenotype, where achieving weight loss is also an important aspect. And along with that, the fibroscan value is showing a stiffness of 9.5 or 10. This is the thing that very obese phenotype with a high LSM value is a rationale where you can use semaglutide with resmetirom together, or you can use tirzepatide with resmetirom together. I was surprised because I was always apprehensive at when we use both the things together, there may be more GI side effects. But I have seen that if we use semaglutide in a low dose and gradually scale up, or you use tirzepatide in a low dose and gradually scale up, along with resmetirom, it is pretty well tolerated. Uh, to enumerate one example, the patient just came today to my follow-up. So he was a case of post-cadaveric liver transplant, 5 years. He has developed morbid obesity with a weight of 126 kg and he had a LSM value of 10.2. So I have initiated him on tirzepatide with resmetirom in August end. As of today, his lipid profile has significantly improved and there is a weight loss of around 12 kgs. His weight has become 113 kgs as of today. Now I am planning to continue this combination for a month more and see the improvement in the fibroscan, because as we have seen that there is a recommendation of 3 months, 6 month and 9 month trend about resmetirom and how do we improve the fibroscan. So I think so that same principle can be used.
Thank you, sir. Um,
So coming to this third question, have you come across any significant changes in the vital parameters or liver scores? So unfortunately, I have to still get a comparative fibroscan data because the patients have been initiated after second or third week of August. I would be starting to accumulate this data and I am sure that I will be able to give this data to the hetero people about the comparative fibroscans before initiating resmetirom and after initiating after around 4 to 6 months, along with improvement in the other parameters. So coming to the common side
common
effects,
side.
as I told you, mainly GI intolerance is the side effect. But I have seen that you should mainly counsel the patient, and as the resmetirom is continued, slowly the GI adaptation happens, and we are not getting that much side effect to the extent that I have to stop the medicine in any patient. The very dangerous side effects which were described, like cholecystitis, and all that, I have not encountered in even a single patient. One patient I would give an example is post liver transplant with a fibroscan of 9.8. I had initiated resmetirom, but within 3 weeks of initiation there was transaminitis and I had to discontinue resmetirom after the transaminitis, and after that the transaminitis improved. So monitoring the AST ALT values is very important when we use resmetirom.
Okay. Sir, is there any dose modification required for resmetirom in patients who are on levothyroxine?
I don't think so. If the thyroid function is optimized before starting, there is no dose modification required. I have used it in many hypothyroid patients without any effect on the thyroid function.
Okay.
I,
So can these two medications be taken together or there should be some decrease in the dosage of levothyroxine?
I don't think so. Any decrease in the dosage is required. I have continued the same dose of thyroid supplement and I have not seen any problem.
Okay. So there is this question of one patient who has reduced 10 kgs in the combination of resmetirom and tirzepatide in one
Yes.
month, where he was having history of high uric acid, and but patient is not able to move his leg because of severe pain. So in such case, can resmetirom be used or it can be continued?
So I think so. These are independent problems. So the high uric acid is mainly a thing of his metabolic syndrome. Uh, but why resmetirom was started in addition to tirzepatide? I think so. We should know what was the thing to start both the things together.
Okay, because the patient weight was 140 kg and he is 37-year-old.
Yeah, but then only tirzepatide can do the job. Why should we add resmetirom to this patient was my question. Do we
Okay.
have a fibroscan value or a MR elastography value was what I wanted to ask.
Okay, so currently we don't have that information with us. No
Ha,
problem, sir.
so,
We can continue
yes.
with the next question.
So can we prescribe patients with fibroscan value of 15? Yes, definitely we can prescribe up to less than 19.5 or 20. We should try to use resmetirom. But obviously we should have a strong watch on the liver function and any evidence of portal hypertension is there on the imaging. Then we should definitely use resmetirom.
Okay. So, is there any data or what is your viewpoint where resmetirom can be used in those patients who have, early cirrhotic stage? Or is there any data which
I
confirms?
have still not used it. I don't think so. There is any data I am aware of. I have mainly used it in these patients who come for an MASLD assessment who have a fatty liver on ultrasound. Then we do their FIB-4 score, and those who are having a FIB-4 of more than 1.5, when we do the fibroscan assessment, I have mainly used it in values between 9.5 to 15, 16. But
Okay,
I have not used it in any patient who has a frank nodular liver on imaging. So I would really not be able to tell that. But I don't think so. We should use it in anybody who has frank evidence of portal hypertension.
sure. Okay. So, what are the absolute lab parameters or monitoring to be done if the patient is on resmetirom? The very
So
mandatory test.
So one is we should have a good thyroid function assessment before the thing, and we should also continue to monitor the thyroid function. As I told you, from one patient, it can also cause hepatotoxicity. So basically, we should monitor the transaminases frequently when the patient is on resmetirom. And third important thing is when we are concomitantly using other molecules, the CYP2C8 inhibitors like the clopidogrel or other drugs, we should be very careful about the use of resmetirom when we use it with clopidogrel.
Okay.
And as I told you, at least every 4 to 6 months, we should try to repeat the fibroscan value, because I shared that algorithm where a fibroscan improvement of 25% is very essential to achieve a good therapeutic benefit with resmetirom. If we are getting worsening of fibroscan values or we are getting less than 25% improvement, then we have to reevaluate the strategy to use resmetirom.
Okay, okay. Sir, just last question. The resmetirom has dosage modification if those patients who are taking clopidogrel. So,
Yes.
are there any other anticoagulant or blood thinners where there are strong drug-drug interactions or the patient need to be very careful?
So mainly it is described with clopidogrel. I think so. Whenever you come across a new drug, it is always important to periodically refer to Medscape or some good drug interaction checker, because any new drug interactions are always reported on these websites.
Okay.
And I think so. You should periodically, while using resmetirom, if you are getting about some unusual drugs in the prescription of the patient, it is always better to check the drug interactions before a resmetirom is started. Other important interaction, as I told you, is you have to reduce the dose of statins. So rosuvastatin has to be reduced to 20 mg and atorvastatin has to be reduced to 40 mg.
Okay, so okay. So with this, we have finished with the questions.
Yeah.
I'll hand over the session to Tanvi right now.
Yeah.
Uh, Thank you so much, sir.
Yeah.
So, dear doctors, as we draw this, I am audible, right?
Yes, yes.
Yeah. As we draw this enlightened webinar to a close, it is my privilege to extend our heartfelt gratitude to all those who have made this event a success. Firstly, a huge thanks to our esteemed speaker, Dr. Vinit Shah, who is one of the leading gastroenterologists and hepatologists of Pune, whose insightful presentation and thought-provoking discussions have enriched our understanding on resmetirom's pharmacotherapy and its clinical approach in MASH. I would also like to express our deep appreciation to our participants, attendees, for their gracious presence despite of their busy schedule. And thank you for active participation and engaging questions. I would also like to thank our Senior Vice President, Mr. Nerudari Sethi, for his generous support and guidance for the webinar. Also, thanks to our dedicated organizing team, our marketing head, Mr. Vikrant Desai, our sales head, ZMs, RMs, and the entire field force that we have. Our medical advisor, Ms. Hetal Goel, and our IT team for their exceptional efforts and attention to details. The entire scientific session was sponsored by Azista. And now, as we conclude, we hope you leave with new insights and learning. please feel free to reach out to us, to any of our team members. And if you have any feedback or further questions, we look forward to welcoming you to our future events. Thank you once again for your gracious presence. Thank you, sir.
Thank you.